Yeah, he had it up too high, and I was standing underneath the speaker.
Okay. So not because it was on. Okay, should we just stand up? Good afternoon. Thank you ever so much for coming to hear this talk. When we were approached by Health Europe to come up with a theme for the talk, we thought we would look at behaviour change through digital. Then we thought we could come up with something much more interesting. So as the presentation started to develop, we realised through so much of the course of our work and so much of the course of the examples we want to present to you today, that we think there is a new view for how we should look at health services. And I think from what Andy told me from the plenary earlier, it seems to be structures and systems and processes that have been a regular conversation throughout the day. So hopefully we're going to take you through this session, looking at both some of the work that we've done, but also in the context of digital and thinking around how we can drive behaviour change. So it is about that, but how we can drive behaviour change using digital technologies. I'm going to stress this is not about systems. This is about digital and digital technologies, the technology that we all have in our pockets that many of you have already got out on your laps today, whether it's laptops, whether it's tablets, whether it's mobiles. So we're going to talk a lot about that. My name is Ian Pocock. I'm the Director of Service Design at Transform. We are a digital transformation consultancy. My colleague is Andy Wilkins, who is our Senior Product Strategist at Transform, and we have something to talk to you about. So I don't know if anybody has ever seen this, but this is a hole-in-the-wall computer. Has anyone heard of hole-in-the-wall computers before? And if somebody was to tell you that a Tamil-speaking child in a southern Indian village can learn the biotechnology of DNA replication in English from a street-side computer, who would believe me? You've seen the talk.
I've seen that,
Yeah. So this is what happened in southern India. A real inspiration, a guy called Sugata Mitra, developed the idea and pioneered the idea of hole-in-the-wall computers. And what he did was he said, I wonder if people can teach themselves, children can teach themselves specifically, using computers, not having teachers, just using each other and using the internet and using connected technology. So what he found was he started off in a slum in Delhi, and by the end of the day, children who never encountered a computer before were browsing the internet, were understanding things about the internet, discovering things on the internet. And someone said to him, apparently, well, perhaps someone came by and showed them what to do. After all, this is Delhi. And so he said, well, okay, I'll go to a southern Indian village where nobody speaks English in this village and very unlikely to have a teacher nearby, and I'll see if I can replicate the experiment there. So he did. Went to southern India, put a bunch of computers under a tree, and said, I'm leaving for 2 months.
That image is from Delhi, though.
Sorry?
That image is from Delhi, though.
The image is from Delhi, yes. The principle is it's under a tree. Very good. Very good. It's hard to find a large enough image of Kalashram where he was. So, but what he did was he went down there and he said, right, I'm going to go for 2 months. And I'm going to come back. So he came back after 2 months. He tested them before he went away. And none of the children, everyone got a 0, of course, on the test, which is what you would expect. So he came back after 2 months and they said, well, we've understood nothing. And so he said, well, okay, well, how long did it take you before you worked out that you couldn't understand about the replication of DNA? Well, we haven't given up. We've looked at it every single day. So you've looked at this every single day and you haven't got a clue what you're looking at and you can't read it. And one of the children said, well, apart from the fact that improper replication of DNA molecule causes disease, we haven't understood anything. So what's the point of telling you that story? he concluded that schools as we know them are obsolete. They're not broken, they're obsolete. And I think we've got a very interesting conversation now at our time in health services to think about the same thing. The health service headlines every day will tell us it's broken and the world, it's not working as it should do. Actually, I don't think that's the point. The point is we are looking at a system that was designed for episodic care, that was not designed for lifestyle conditions that are causing most of our long-term conditions, lifestyles that are causing most of our long-term conditions and resulting in our poor later health, which is costing the NHS all the money. And when we think about it, we think that, as Abraham Maslow said, the man with a hammer sees everything as a nail if that's his only tool. Well, for the NHS, the hammer is money. The hammer is we need more money, and we have a perverse incentive within the NHS, or within the health system, not just the NHS to be fair, but the health system, that we have to spend more money on treatment. So we spend 95% of our money on treatment, of treating diabetes, costing 10% of our NHS budget, instead of and taking 5% and putting it into prevention. Well, imagine if we changed that. Imagine if we used new tools, new technologies, and invested in those services. So we're not spending 5%, but 20%, even just 20% of our money on prevention and preventing the lifestyle conditions that lead to things like COPD and diabetes. And the fact is that, the money is diminishing. The money is running out. Old conditions being caused later in life that's costing so much of our money, when actually using things like mobile technology, looking at interventions that can change behavior much earlier on in the process. We'll talk to you a bit later about a tool that we've developed for Public Health England, which is specifically designed for 40 to 60-year-old adults, designed on the premise that if between 40 and 60, that's your chance to change your behavior, change your lifestyle, so you can prevent those conditions coming on. The investment that's been made in that is a really small amount, but a huge number of people have consumed that product. So this is my man with my older man with long-term conditions, smokes a lot, Gandalf. We stand there in the health system and say, you shall not pass to the Balrog, but everyone forgets that the Balrog dragged Gandalf down into the abyss, because you can only stand there for so long trying to fend that off. When we look at the cost of type 2 diabetes on the NHS, 80% of diabetes is type 2 diabetes, and mental health on its own costs £77 billion to the UK economy, roughly the size of the structural deficit in the UK. There are services that are not being provided because of the cost of that, but technology, thinking about how we design those services, thinking about the needs of users, we can design those services in new ways that provides early intervention, that looks at how we change the behaviours, so we get people to behave in a different way around, whether it's eating, whether it's smoking cessation. I worked on a program a few years ago which looked at smoking cessation. And instead of targeting people that smoked, it targeted the influences of people taking up smoking. So it was aimed at much younger people, so try and reduce the number of people taking up smoking. And it looked at those trends. So it identified that roughly the same number of people were giving up smoking as taking it up. So if you could actually reduce the numbers taking up, that's where you would have your effect. And that was a reasonably successful program. It was called a social influence model. And everyone's recognised what the answer is. I mean, even the 5-year forward view talks about what the answer is. But I think the challenge is, how do we get from where we are today to the world where we are investing in prevention? And one of the biggest challenges that I think at the moment is that it is focused on people delivering these services. We work a lot with CCGs, work a lot with CSUs, and looking at the conversation always comes back saying, well, how are we going to provide it? The system doesn't support it. Our technology, our infrastructure doesn't support what it is we're trying to do. So the key thing that we're trying to focus on in our work, and so much of our work, is saying, put technology to one side. Think about what it is that patients need, what is it the public need, what is it that users want to engage with. work out what's likely to shift their behaviours. What are their circumstances all about? Who are they? How do they live their lives? Deal with the technology at the end of it. Deal with the digital tools, deal with the services, just as a way of providing that. But focus on what the user need is, what's likely to shift their behaviour. So where does this go? Where do we take these services? We think it's technology, clearly. There are tools, there are products, there are services, there are a multitude of apps, there are a multitude of different types of technology, and the challenge for us is to make sure we understand how we can interpret the landscape of tools. So it's not just we can build loads of cool stuff, and that's great, but you know the NHS is filled with lots of pilots and lots of prototypes that are very cool technology. But how do we know what the right ones are to use? When you think about collaboration, this can't be a solution that is designed and owned entirely within the health system. This has to use the really smart people in not-for-profits, the academics, the partners in technology companies who understand different facets about engaging with people and engaging with individuals, and also the subject matter expertise around those conditions. We'll talk a bit later about some of those areas where we've worked, which partnered technology companies with experts in particular types of health conditions and made huge differences in people's lives. And it's about the community. Overwhelmingly, people are influenced by their community, by their environment, by where they live. They don't want to necessarily be different from that community. One of the things we've found in our work in public health is trying to get the behaviour change. People don't want to stand out. People want to be part of their community. So how do we get the community to change? And there's some experiences we've had there. And this is kind of my vision of when people come and talk about digital and technology. It's kind of a crazy world where you can have loads of cool things and loads of great ideas that can come up. But it's a bit scary. It's a bit, we have to go through the looking glass and what's going to come out the other side? Well, we might get an app, we might get a website, we might get a new diagnostic tool, loads of different things, but how does it all knit together? And I think that's one of the great, one of the things that the technology has not done well, or technologists have not done well with the health system, is we haven't looked at how you piece that all together in a systemic way. How does it actually serve those that are trying to provide the care on the ground and deliver benefits in terms of patient care on the output, but also help those who are delivering the services to provide better ones. So I think part of the challenge of technologists is or technology and design, is to think about how you bring those different disparate parts of it together to make a much more effective outcome. So I'll let Andy talk to you about some of the work that we've done, which hopefully will provide you some real interest.
Excellent. Thank you very much, Ian, for that. So he set the stage nicely. There's a big challenge here. Technology has a role to play, but it needs to be seen in the context of a system that's already there that needs to also think about changing, and also about a recognition that we need to get deeper into understanding how people live their lives and how best, through behavior change, to use technology to make the better outcomes that we all want. I'm going to spend the next 10 minutes or so going through quite a lot of things. So I hope you kind of awake and got your brains ready. I'm going to take you on a journey to whole system populations right down to individual behaviors. And I'm going to do it quite quickly. So hopefully you can follow me on this journey. One of the things from the work that we've been doing across public health and into the healthcare system is that there are a lot of actors involved in the provision of service. So we all know that there are a lot of silos that need to be addressed. And so when thinking about how we change solutions, it's not just about the technology, it's about how the underlying system also needs to sort of adopt and change its way of operating to make use of the technology to deliver the change that we all want to see. One of the interesting things that not many people are kind of aware of, but it becomes quite evident when you think about it, long-term condition patients. Now, Kaiser Permanente did an interesting study, you might know them, one of the leading providers in the US, of how much time does a long-term condition patient actually spend in front of a healthcare professional, and how much time do they spend on their own managing their condition? And what they found is that less than 0.1% of a long-term condition patient's time is actually spent with a healthcare professional. 99.9% or more is on their own coping with the condition. But guess where all our focus is? It's on the 0.1%. Health is delivered, managed, achieved by how well people cope in the 99.9%. And that often is white space for the healthcare system, but a real opportunity where digital can step up and start to play a role in helping people in that field. Now, this was brought to life quite vividly by a piece of work we did with the Royal Free Hospital. And they wanted to understand, how do patients flow through our system? We looked at it for outpatients, not inpatients. How do they flow from the moment of referral to the moment of discharge? What is the journey they go on? And what does it feel like to be a patient through our hospital outpatient service? Because we want to do some work on realigning and doing some development of outpatients, but we've got an internal perspective where we want to shift things along to make things work for us economically. But what do patients think? What do they need? So what we did is did a deep dive survey with a number of patients to understand what their journey was through from referral to discharge, largely through the hospital, a lot of appointments, either one-off or people coming for many appointments. And we identified a whole bunch of really profound problems and issues that patients have to deal with, largely because it's a very siloed experience. You arrive at the hospital, you get a kind of an experience when you walk in, the front office staff will direct you, then wander through the hospital, get lost. You might arrive at a clinic. Where do you go? How do you have to sit there often for an hour or two, and then the parking meters run out. And when you follow patients through, you get this sort of horrendous story, especially if they're multi-long-term condition patients, because this is going on in parallel now. So you build up this very sort of painful journey that patients go through, that once understood provides some sort of context to how that could be supported. However, this is what the hospital thought was the sort of key journey. But when we interviewed patients about what really matters to them, they talked about managing and coordinating my appointments. They talked about the relationship with their doctor and their care team and how that gets sustained beyond the consultation. They talked about walking away not understanding their condition, not understanding their treatment, to be able to manage their own condition or activate their own support networks. They talked about being able to manage their condition in the context of their life. What changes do they need to make, not only to diet and lifestyle, but if they're working or they've got relationships, how do they deal with these tensions? Carrying out ongoing tests and obtaining ongoing supplies and support for queries or emergencies. What we found was over 400 unmet needs, and many of them sat in this space. But when we asked the same questions to the hospital staff about what's important to patients, what do you think, clinicians, consultants, front office staff, they came out with a list of things. Many of them were important, but what was very clear is that, as Ian was saying, if you've got a hammer in your hand, everything looks like a nail. So the clinicians would look through the lens of what they do, and they would see a patient, and they would identify what they thought mattered to patients. The front office staff would do the same, nursing would do the same. So you've got this picture of what the hospital, who works with patients every day, thought was important. And then we put it against what patients said, and it was like chalk and cheese. The people who work with patients every day did not come up with the same sort of needs that patients expressed as were important to them. So it really shows the value if we're going to start making significant headway, not only improving how outpatients works as a function, but how we support patients on their long-term condition journey. It really needs this outside-in view. And we know that over 40% of the outcomes to do with long-term conditions are to do with how well patients support themselves, understand their conditions, and adhere. There's a crying need there for support, and we think digital is one of the areas that can really start to provide people with support around that journey. But again, it can't be atomized bits of support. We need to start thinking of this more holistically to help patients on this ongoing journey. So We know that we have multiple silos across multiple functions, all doing a fantastic job in the most difficult of circumstances. But if we don't start to think about how patients flow and how we manage these handoffs and how we help patients through these journeys, then the possibility of new technologies is not going to be realized unless we start working in a more joined up manner. And I would argue that understanding how patients flow through what their experience is a really important insight into thinking about how we tackle this challenge, or else we start doing this kind of alignment based on what our internal perspective is without really truly understanding what gives the best experience for patients. So what we've basically pushed forward is a term, I don't know how many of you are familiar with it, called design thinking. It's a new way of thinking about problems. Now, most people start here. They come up with some ideas. We have some brilliant ideas about how to do X, Y, and Z. Let's do this. Let's build a business case, and off we go. When we look externally at how successful that way of doing things is, here's an interesting stat for you, and it's not just in healthcare, it's across all industries. Over 90% of new services, products or services, fail to achieve the outcome that was hoped for them, 90%. And the reason isn't that people aren't good at developing stuff. The reason is they never truly understood the nature of the problem they were trying to solve. So the key to really understanding how to do service transformation is to go right back and understand what is the nature of the problem we're trying to solve. How is it experienced? Who are the actors involved and what are their angles on this? Let's understand that problem space in all its dimensions. Let's then break that down and define what are the potential solutions that might solve some of this, that then allow us to think about how we would generate an idea that we could bring to life, that we can then prototype and test quite quickly so we can get some feedback and learn, and maybe we need looped around a couple of times to understand what works and what doesn't, till we then have something that we can then roll out. So this way of thinking, this kind of design-based thinking, lies at the very heart of trying to understand what the nature of the problem is and how best we move forward to solve it. How many of you are familiar with the behavior change wheel? Some of you. This is another interesting tool to think about. As you've probably been hearing in the news about economics and after the crash, guess what? People don't behave rationally. They don't make rational decisions in the way that we sort of assumed and hoped that they would. They're very irrational. In fact, people make decisions in all sorts of irrational ways. And so some interesting work has been done by Susan Mickey at University College London to really pull together all the behavior change insights and research and formulate an overall kind of behavior change model that helps us think about how people make decisions, what's the weaknesses and the biases in their psychology that allows us to start to create services that connect with and understand that rather than have services that miss it. So the three key areas is capability. Has the person got both the psychological capability? Do they understand? Do they know what's being asked of them? And do they have the physical capability to carry something out? Because we need to stage some interventions to support that. So the capability is one. Opportunity. Are there resources available for them to make those choices that we want them? Have we designed what they call a choice architecture that lays things out to allow people to make the right choices? Have we, as Ian said, created or have the ability to sort of nudge social norms to involve the community in terms of making opportunities more available, more attractive? And finally, have we been able to create the right level of motivation? What inspires people to want to make a change? And what are the things that are stopping them? Do we understand what those are? Can we reach in and speak to those to reduce the things that act as blockers and leverage the things that are likely to motivate people? Now, here's a little bit of a busy diagram. I can see you going, where's he going with all of this? Health is massively complicated. It is complicated, which is why it's such hard work. But we know increasingly that mental health affects physical health, and physical health affects mental health. There's a complexity here that we're only just starting to understand. And people exhibit a whole bunch of behaviors that we're interested in. They're moving ones, they're consumption ones, eating, drinking, addictions, and mental health behaviors. And these behaviors are often related and interconnected. And quite often we miss it when we go through one behavior at a time. The interconnection of those behaviors often cluster together. But these happen in the determinants, the contexts of health. So where people live, what access to resources they've got, whether in healthy relationships, whether they've got finance or not. These all then impact on the sorts of decisions they make. It gets quite complex. But we do and are able to do a number of tests, and we do screenings, like the national health checks. There's a number of other screenings that start to identify when people are exhibiting risks that indicate poor health. So although we might communicate with them around here in a pure prevention, when we are able through screening to be able to identify a risk factor, it offers another opportunity to talk to people with the sense more urgency around these behaviors. And ultimately, if they do get sick, of course, with a long-term condition, all these behaviors are still relevant, but now need to be orchestrated around the particular long-term condition. So thinking about people more holistically and the multiple factors that affect are part of the greater understanding that we need to get around how we support people. Now, the fascinating new role that mobile, in particular, can play in this is that mobile is something that people carry with them every day. Now, 80% of the UK population now carry a smartphone. The average amount of time that a person spends looking at a screen is 2 hours a day. The average number of times people check their phone is 150 times a day. As people are going through these behaviors, their mobile is with them at every stage. Mobile gives us a really fascinating opportunity to get into the heart of how people live, to both inform, to trigger, to nudge, to support them in making the changes that they often want to see themselves. So it's an incredibly important and powerful platform to get into this world. So I'm going to talk a little bit now from less theoretical, more to stuff that we've done, where we've tried to bring some of these to bear on real concrete examples. So recently, Public Health England did a big sugar campaign. How many of you downloaded the Sugar Smart app? A few of you. Oh, these public health people didn't learn it. The Sugar Smart app was part of the campaign to drive awareness of sugar. And this has been spectacularly successful, much more successful than Public Health England, in fact, expected. So we designed a sugar app that sits on a phone, you download it, and it's uses the camera to be able to scan a barcode, and then up pops on the screen how many sugar cubes is in that drink, in that package, in that whatever. So there are a couple of things there. One is that we're making it extremely easy at the moment that people are quite interested in how much sugar does this have. Bam, their phone is with them. Click, bam, on the screen it comes. And using the currency of sugar cubes, which is a very visual way of seeing how much sugar rather than how many grams, and what does that mean? Sugar cubes have a very distinct impact. People can see that. 2 million people, 2 million downloads of this app to adults and children who became sugar detectives going around. Oh my God, oh my God. And in it, we built a share function so you could share that. Did you know that? I'm going to share that. So we turned essentially 2 million people into sugar detectives that went, oh my God, new relationship with food or drink they never had before, and the possibility to share it into their communities, to share this news. So a fantastic example. David Cameron had the Pepsi-Cola and a whole bunch of others knocking at his door trying to get it shut down. Actually, the food industry got quite upset about this. But that's a sign of success, the food industry upset. Smoke-free. I'll tell you a little bit about some work that we're doing very quickly on smoke-free. Smoking is one of the really interesting areas. It is in some ways quite a discrete habit that we can tackle as one discrete habit. Now, I don't know how many of you are familiar with the smoking stats. There are about 8 million smokers still in the UK. We have local stop smoking services available, but the catchment area that they exist in is only available to about 5 million. So there are 3 million smokers who are not even the catchment area of local stop smoking services. Another stats for you, 40% of those 8 million try to stop smoking every year. Do you know how many are successful? 4%. 4%. It takes an average of 14 quit attempts to stop smoking. It is hard to stop smoking. So what we did with Public Health England again is saying, well, you can just provide an app that tells you to stop smoking, but that isn't going to get into the heart. Smoking is hard. So we went and worked with Professor Robert West, again at UCL, as it happens. UCL seem to have quite a, well, UCL, Robert West and Susan Mitchell are actually married, which is quite interesting. Didn't know that. But so Robert has designed the behavior change program that sits inside local stop smoking services. So he's done a lot of academic work on terms of how do you create and script a transformational journey to help people manage stop smoking. So we got from Robert, with his collaboration, the behavior change techniques, and then we codified that into a journey. Pre-quit, helping people to figure out why they want to stop smoking, the nature of their smoking habits, so be able to collect that and understand that. Certain things that you need to change in your environment, making a commitment, that making it public. These are all techniques that Robert identified that we've codified into an app journey that helps people prepare for their quit. In fact, there's more work done pre-quit than there is in the quit. Quit itself becomes an important day that you communicate, you can get various people to support you on that journey, and that first day and the first couple of days are the key ones to help people in their quit attempts. So by capturing their daily patterns of smoking and what triggers there are, we've been able to start thinking about how you script something that will prompt you and trigger you and support you through the difficult moments of your smoking journey, that then allow through the coming 28 days a daily support that gently tapers off as you make success, with weekly check-ins and reviews, very much mirroring some aspects of local stop smoking services, but this time with you continuously to support you. With the option of an SOS, so you can tap that and contact your favorite friend, or possibly even in the future into local stop smoking services. Very rich, very integrated, the opportunity to take local stop smoking or stop smoking advice out to 8 million people in a way not been able to do before. Now, I'd like to finish off with how are you? How many of you have taken the quiz, the How Are You quiz, as part of the One You campaign? Again, a very small number of public health people. So we've been instrumental in working, again, with Public Health England on the How Are You quiz that sits within the One You campaign. And again, we were there not only to do some of the digital design and support, but also do the behavior change, thinking about why would you do a quiz and how would you create a quiz experience? So, One You does its big TV campaigns. There's only one you. Come and do this quiz. People come to the quiz. And what we had to think about was, how do you design a quiz that just doesn't sound like public health being all pointy-fingered at you and telling you, how do you draw people into a quiz? So what One You did was get people to think about the notion of One You as being important, get them curious enough to be able to come into the quiz. And then we structured the quiz, not with how much do you smoke, how much do you do, how are you? How do you feel right now? To get people to think about themselves right now. How are you in terms of what do you want to change? What's important to you? something about you. These became really important things to get people to reflect upon it. So when we could go and give them their results, we don't just say, you smoke too much, da, 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 da. We can put the results back in terms of how they said they felt and what they said was important to them. So yes, we did the questions around these behaviors, but they all led to a set of results and a narrative scripted around each individual, depending on what they said, to give them personalized results in the context that mattered to them. So it got them to think about these behaviors in the context of their life. How does this apply to me? Not just the pointy finger, but how does this apply to me? Internal reflection that then acts as the motivation to change. And that change then may be something they do themselves, or this is where digital tools, once you've got people, yeah, I do want to change, you need to provide at that moment the right digital tools to do it. So I'll give you an example of one of the questions. People who've done it will have seen this. It's taking a different type of user experience approach to how you do this. It's not typical public health language. In fact, the health policy people got quite jittery about the sum of language here. But making it really easy, talking in the language that people would use every day. This came out of the research. It needs to feel real. It needs to feel like the language we'd use to talk to each other, really knackered or full of beans. That's a different way of speaking, but and doing it on a slider as well. So it's very simple. You don't need much digital expertise to be able to understand and navigate your way through that. And guess what? We've had over 1.1 million of these completed. Way exceeded Public Health England's expectations, over 4 times more than they expected. This is massively rich data, self-reported data about how people feel, what they're doing about it, where their health behaviors are, which are largely coded with postcodes. So there's an opportunity to circulate some of that data back into local authorities, say, what's going on in your local authority around this, which helps real-time data about what's going on and where people are in their journeys, which I think is a really exciting part of where this digital journey it gives us data we can share and get some understanding. So some of the apps that sit off the back of that, which we've helped sort of redesign, Couch to 5K. So if people were scoring low on movement, then here's an app that supports you in getting off that sofa and being able to take your journey to being a fitter, healthier person, and also the One New Drinks tracker to help people get a better sense of what they're drinking and what they might want to do in terms of nudges and improvements and alternatives. So hopefully that's given you a rapid journey through some approaches. It's not just about digital, it's about new ways of thinking outside in, and trying to get the system to think about using that insight to help with its journey of change. Then digital can really start to make these transformations and close the gap that Ian talked about. So I'll hand over now to Ian to round off.
Just want to give you one very quick example of, we talked about community earlier and the importance of community in this process. And we work with NetMums. A few years ago now, started in 2007, and the hypothesis was, can you use a social community to support mums with postnatal depression? And what we found was, and I'll just go so I can read the stats to you and be absolutely right. We ran it for 3 years. The overwhelming majority of their users in their forums had some level of issue with depression. The importance of what they were able to provide was they were able to provide normalization, a forum for safe discussion, a place where people didn't feel stigmatized in having that conversation. It became profoundly important, and it prevented, in some cases, some very serious consequences from social communities. So to give you an idea of the stats, and this is where I want to kind of leave you with the idea of value, that we can look at technology and community and collaboration. We had it evaluated by Matrix Knowledge. Every year, NetMums, it's bigger now, but when we finished with working with them, every year NetMums contributed to 8,300 cases of avoided postnatal depression. A further 1,200 mothers avoided severe postnatal depression. It contributed to 26,000 GP visits that were avoided, unnecessary visits avoided. 53,000 health visit appointments didn't need to happen, so they could focus on other areas with other mothers. Yeah, the value was £8 for every £1 that was invested by the Department for Education in the Net Mums community. Now there are about 5 million users of Net Mums. When we started with them, there were about 300,000. It grew to 5 million today. It still provides a vital service. It's no longer publicly funded, the Parent Supporters Service, which supported mums on those issues. But the impact of community on normalising issues that people don't want to talk about is incredibly powerful. And you align that with technology, and you realise the value of investment versus the value of return is huge. So we'll stop there and say thank you very much. Appreciate we're running into your lunch hour, but thank you for your time. Any questions, you're very welcome.